Yes, good evening, friends. I am Dr. Avnish Goyal, a senior consultant dermatologist and aesthetic laser surgeon. I have post MD clinical experience of around 15 years. I am an educator and orator in dermatology, sexually transmitted diseases, lasers, and various aesthetic procedures. More than 25 publications are there in my name. I have vast clinical experience. I am also a fitness freak and my Telegram group name is Dermatology by Dr. Avnish and the link is mentioned here. So let us crack NEET PG with India's largest learning platform, that is Unacademy, wherein you get daily live classes, you get live tests and quizzes, you have a structured course and unlimited access to the live and recorded classes. So these are the subscription rates. The 1 month subscription cost is around 4,500 rupees, and if you use the code Dr. Avnish YT, you get additional 10% of the discount. So 10% of the discount. So let us start with the multiple choice question of AIIMS that were asked in the June 2020 sessions in dermatology, and this is your first question. So anybody with the correct answer, the topical antifungal agent with antipruritic action. So if there is no one of time, the correct answer is sertaconazole nitrate, which is a topical antifungal agent with antipruritic action. So let us talk about the mechanism of. So mainly the azoles antifungals, they are divided into two major groups, the imidazoles and triazoles. They act, the mechanism of action, they act by blocking the lanosterol 14 alpha enzyme, which is necessary for the ergosterol synthesis. And ergosterol, it is an essential component of the fungal cell membrane. I think you must be aware of that. Told they are classified into imidazole and triazoles. So imidazoles further they are classified into lancoconazole, fenticonazole, sertaconazole and ibuproconazole. So these are the important one. They have the, apart from having the antifungal action, they have got certain different action also, like lancoconazole, it is an anti-inflammatory agent along with antifungal property, and it has got a wound healing property. The fenticonazole, it is an antibacterial as well as an anti-protozoal drug. The sertaconazole, it is anti-inflammatory and it has got anti-itch activity. So this was our question. Ibuproconazole has got antibacterial and anti-inflammatory activity. Apart from this, the butynaphine in benzylamines, it has got anti-inflammatory activity. The cycloperoxolamine, it has got antibacterial, antiparasitic, and amrolfin, it has got antibacterial activity against actinomyces. So this is the main antifungal drugs. Apart from being the usual antifungal activity, they have got the inflammatory activity and so on. So this data has been taken from this table, which clearly says that inflammatory activity and anti-itch activity. Now this is the reference taken from this journal with butoconazole, cycloperoxolamine, fluconazole and miconazole nitrate has got anti-inflammatory activity. So is sertaconazole nitrate, but sertaconazole nitrate is far greater than other topical antifungal agents. Apart from being the anti-inflammatory, it inhibits the scratching response. So these are the actions. This data clearly says that cetaconazole has got an activity apart from normal antifungal activity. Coming to question number 2. So this question was repeated in AIIMS May 2019, also in AIIMS June 2020. So anybody with the correct answer? So this is about the chick sign of chikungunya. So this is also called as post chikungunya fever pigmentation, which is common in all age group. It presents as asymptomatic brownish black macule, which can be there either into centrofacial area of the face, or it can present as diffuse pigmentation over the face, and it may mimic the melasma. Usually this sort of pigmentation they develop 2 weeks or more after fever, and it is a common feature of chikungunya fever in India, the post chikungunya fever pigmentation. Yes. Now the chikungunya, it is a triad of fever, arthritis and skin rash. Now these are the manifestations. The smaller joints are involved, so there can be the edema over the dorsa of hand and feet. There can be the presence of maculopapular rash, and there can be the involvement of the joints. So the arthritis can be the manifestation of chikungunya. So the rash of chikungunya, they can be of many types. So this is the pigmentation over the face as a manifestation of chikungunya. There can be the morbilliform rash, which is the most common presentation. There can be the presence of petechial rash. So this petechial rash can be the manifestation of chikungunya. Involvement of palms and soles can be there. There can be the eczematous rash in chikungunya as well as morbilliform rash. So there can be many type of manifestations of chikungunya fever. Now coming to arthropathy, the joint involvement in chikungunya, usually it involves greater than 10 joints. Though it has got predilection for the smaller joints of the body, it can also involve the large joints. The hip joint, it is relatively spared in chikungunya, and the pain in joints, it is severe enough to immobilize the patient, and it interferes with the sleep in the night. So these are the manifestations of chikungunya, which can be in the form of the cutaneous manifestations as well as joint involvement. So this is the images of the joint involvement. So it says that the smaller joints of the hands and feet, they are commonly involved, though there can be the involvement of larger joints, and there can be associated swelling of the joints in chikungunya. Coming to question number 3, again it was a repeated question asked in AIIMS June 2020. So this is about the flagellate pigmentation of skin, and it is secondary to bleomycin. So this was a repeated question asked in AIIMS 2020. So this is the flagellate pigmentation of skin, which is commonly seen due to bleomycin. So let us discuss the pigmentation due to chemotherapeutic drugs. So first and foremost, the flagellate pigmentation, which presents as multiple streaks or hyperpigmented streaks along the site of scratching or trauma. So this is called the flagellate pigmentation, and commonly they are due to bleomycin. Now coming to the other type of pigmentation due to chemotherapeutic agents, the linear pigmentation or the serpentine pigmentation that usually follows the course of the veins and they are proximal to the infusion site. The cause can be the vinorelbine and daunorubicin. Then coming to the reticulate pigmentation, the hyperpigmentation, the combination of hyper and hypopigmentation mainly over the trunk and lower limbs. The etiological agents can be paclitaxel, cytarabine, idarubicin. The hyperpigmentation of the sun exposed area, the cause is methotrexate. The diffuse pigmentation of skin and mucous membranes. So the skin and mucous membranes, they are involved. It is due to busulfan, cyclophosphamide and procarbazine. And lastly, the hyperpigmentation of the small joints of hands and feet along with palmar creases, and the etiological agents for this can be cisplatin, docetaxel, doxorubicin and idarubicin. So these are the drugs, chemotherapeutic drugs, and the common pigmentation associated with them. Coming to question number 4. Yes, anybody? Dr. Bhivam Raj, you answered it correctly. The methyl isothiazolinone. The methyl isothiazolinone, it is used as preservatives in cosmetics. Yes, you are absolutely right, Dr. Bhivam Raj. So this is the preservative. So both methyl isothiazolinone and methyl chloroisothiazolinone, they are common preservatives and they are used in liquid personal care products just like cosmetics, lotions, moisturizers, sanitary wipes, shampoos and sunscreens. However, they are associated with lung toxicity, allergic reactions and possible neurotoxicity. So both methyl isothiazolinone and methyl chloroisothiazolinone, they are used as preservatives. Question number 5. So anybody with the correct answer for question number 5? So for the given question, no, it was not a repeated question. The question number 5, for the given question, the correct answer is don't involve in sexual intercourse when active lesions are present. So prophylactic antivirals. So there is no role of prophylactic antivirals. Maximum is that you can give the vaccines, the prophylactic vaccines to the patients, to the husband. So that is to prevent the spread of human papilloma virus. So the most appropriate answer is the choice A, don't involve in the sexual intercourse when the active lesions are present. So let us have a look about the human papilloma virus and warts. So first of all, the basics. So genital warts, the benign growth of the genital warts, they are associated with human papilloma virus 6 and 11. However, the metaplastic growth, they are associated with HPV 16, 18, 31, 33, 35. You all know this. So they start as a soft flesh colored papules which may coalesce, which may join together to form cauliflower like masses. The site in men, it is most common over the glans penis, coronal sulcus, prepuce and shaft, followed by the shaft of the penis. In women, it is the labia followed by perineum, clitoris and fasciae as the site of genital warts. And all the women who are affected with genital warts should be screened for cervical intraepithelial neoplasia by the process called as acetovaginine. Now these are the images of genital warts. So they start as papules, they may coalesce together to form plaque. So the first image is in females, second image is in males. Now the virus, it enters through the defect in the epithelium through the defect caused by trauma during sexual activity. The virus, it invades and replicates in the basal layer. So virus is localized to the basal layer. The infected epithelial cells, it is the infected epithelial cells which proliferate to produce the clinical lesions of condyloma acuminata. So the viral DNA is found in the basal layer while the infected virus particles, they are found in the superficial layer. What about the course? So the lesions may progress, they may enlarge, they may remain unchanged, or they may undergo malignant transformation. The chances of getting for the malignant transformation is low with type 6 and 11, while it will be high with type 16, 18, 30, 31, 33 and 35. So these are HPV serotypes. Now the incubation of warts, it is long and variable. It varies from 3 weeks to 8 months. Now the low risk HPV type, the type and 6 and 11, they are frequently associated with warts. Now you must be knowing that warts, they are transmitted through direct skin to skin contact, usually during oral, genital or anal sex. How about the treatment of warts? So treatment of genital warts, they are with podophylotoxins or the podophyllin. They can be done with imiquimod with the application of trichloroacetic acid, and you can excise them surgically. The treatment of genital warts, what can be given to the patients? So that patients themselves, they can apply topical imiquimod after the prescription. So it is applied 3 times a week for 16 weeks. The patients can apply podophyllos gel. So the concentration is 0.5%. I want you to know the concentration. It is applied twice daily for 3 days a week, followed by no therapy for 4 days. So in total in a week, you have to apply only for 3 days a week, that too twice daily. And this sort of cycle has to be repeated for 4 cycles. Now another drug which can be given to the patient is cyanocatechins. It is a green tea extract, should be applied thrice daily for 16 weeks. So these are the drugs which you can prescribe on a prescription and patients can apply themselves. What are the treatments which a doctor should give? So the doctor can treat the patient with cryotherapy, with liquid nitrogen, with surgical excision of the warts. He can cauterize the patients. The laser excision can be done with carbon dioxide laser. They can be cauterized chemically with trichloroacetic acid in concentration of 80 to 90% and podophyllin resins. Now here the concentration is 10% to 25% and they are applied once in a week. So the doctors, they should apply the podophyllin resin, and it should be applied weekly. Finally, about the prophylaxis of HPV infections. So for prophylaxis, you can do it with vaccines. Two vaccines are there: bivalent, which protects against type 16 and 18; the quadrivalent, which protects against type 6, 11, 16 and 18. For boys and girls who are younger than 15 years, you need to give only 2 doses according to WHO classification. The timing of doses is 0, that is at the baseline, and second dose after 6 to 12 months. And for males and females who are older than 15 years, they should be given 3 doses. The doses are 0, that is the baseline, the second dose after 1 to 2 months, and the third dose after 6 months of the first dose. So this is the prophylaxis of for HPV infections. It is done with the vaccines. So there are no drugs which can give the prophylaxis against the HPV infection. Finally, the prophylaxis, the vaccines can prevent the cervical and penile cancers as well as genital warts if they are given before the patients are exposed to virus. So there is no role of any antiviral in the prophylaxis of genital wart. So you can use the vaccines, that too before the patients are exposed to the virus. Question number 6. Yes, almost all of you are right from Arun Ashok, Boy Good and Kishore. So this is certainly the bizarre shaped lesion over the face, and this is dermatitis artifacta. So I'll read out few lines for you to which pertains to the diagnosis. So what is dermatitis artifacta or factitial dermatitis? So dermatitis artifacta, it is the lesions are bizarre shaped. They have an irregular outline in a linear or geometrical pattern. So the lesions are clearly demarcated from surrounding normal skin. There can be very many type of lesions. They can be red patches, they can be swellings, they can be blisters, denuded area, crust, cuts, burns or scars. So these lesions can be produced by a variety of mechanical or chemical means, including fingernails, sharp or blunt objects, lit cigarettes and caustic chemicals. They do not evolve gradually. So they almost emerge overnight without any prior sign or symptoms. The sites of involvement are usually the readily accessible sites, and patients, they usually deny that the rash is self-induced. So it is the dermatitis artifacta. It is self-inflicted dermatitis. It can be many type of dermatitis, and it is usually which emerge almost overnight. Question number 7. Yes, it is a sort of malingering. Yes, certainly. This is the history which pertains to epidermolysis bullosa. Yes, Arun, you are true. So is Kishore. So you both are true. So this is Sachin, you are also correct. So this is the epidermolysis bullosa. Now we know that there are three inherited type of epidermolysis bullosa and one acquired type. So first of all, let us notice where the defect in epidermolysis bullosa is. In epidermolysis bullosa simplex, it is in the stratum basale, wherein the defect is in keratin 5 and 14 proteins. In junctional epidermolysis bullosa, the defect is in laminin 5 and 6, that is at the junction, dermoepidermal junction. And dystrophic epidermolysis bullosa, it is in the upper part of the dermis, wherein collagen 7 is the antigen. So first and foremost, epidermolysis bullosa simplex, wherein the defect is in the basal layer. So it is an autosomal dominant condition which begins at birth and infancy. You will see blistering at minimal trauma. Now I want you to notice these two lines. Usually the epidermolysis bullosa simplex heals without scarring. Mucosa, nails and teeth, they are spared. The defect is in K5 and K14 protein, and the split is in the basal layer or above it in epidermolysis bullosa simplex, and it is non-lethal. Now coming to epidermolysis bullosa junctional. This is autosomal recessive. It begins at birth. It is of two types, the Hurlitz, which is a lethal variant, and non-Hurlitz, which is a non-lethal variant. Now here the mucosa, nail and teeth, they are involved, and the lesions, they heal with scarring and milia formation. Here the junctional epidermolysis bullosa, the defect is in laminin 5 and 6, also alpha 6 beta 4 integrins, and the defect is at the level of lamina lucida in the dermoepidermal junction. Now coming to the third one, the dystrophic epidermolysis bullosa, which can be autosomal dominant and autosomal recessive. The recessive forms are more severe. Again, the mucosa, nail and teeth, they are involved, but hands, the lesions, they heal with development of contracture. So this is important. So the development of contracture is quite characteristic of dystrophic epidermolysis bullosa. So it may end up with the mitten hand deformity, esophageal stenosis. The defect is in anchoring fibrils, the collagen 7, and it is below the lamina densa. So mainly the lethal variants can be the junctional variant, or it could be the dystrophic variants of epidermolysis bullosa. The dystrophic ones, they heal with the contracture, while the junctional one, they may heal with the scarring or milia formation. So this is all I wanted to tell about the MCQs of AIIMS. So I urge you to attend free live classes plus courses and batch courses on Unacademy platform. My referral code is Dr. Avnish-YT, and you will get additional 10% of discount if you use this code. You can also subscribe to the Unacademy Live NEET PG on YouTube, and also Unacademy NEET PG Live on Telegram. My upcoming classes on YouTube will be image-based discussion on dermatological conditions. I will be discussing high-yield multiple choice questions and previous year's questions of JIPMER, and there will be a quiz on STDs and leprosy. About the free special classes in June on Unacademy, what I have completed previous year recall questions of AIIMS. I have completed previous year's recall questions of JIPMER, and I am upcoming with the previous year's recall multiple choice question for FMGE. Now I want you to like, share, give me a comment if I am right, and you can subscribe to this YouTube channel, and you can press the bell icon to get the notification. And with this, I say thank you very much for patient listening, and good luck for your examination. Thank you very much.